Please allow me to now introduce our speaker for today's session, Dr. Jessica Duis, Assistant Professor with Genetics and Metabolism, Children's Hospital, Colorado. Thank you all for joining us today. Now let's begin.
Thank you, Sabrina, and thank you all so much for having me today. As Sabrina said, I'm going to be talking about Angelman and Prader Willi syndrome, which are both caused by a missing part of chromosome 15. And so I titled this talk Chromosome 15 Disorders. I did want to warn you all that I am going to stop share in the middle to share a video if I can get it to work, and then switch back to the slides. So if you notice that everything is going as planned, I just couldn't get it to embed into the PowerPoint, but I think it's a very valuable video to watch. So today we're going to talk about the clinical features of Prader Willi and Angelman syndromes. We're going to talk a little bit about management and talk about the genetic cause of both of them. And then we're going to just talk about the therapeutic journey, in particular for Angelman syndrome and where the field is today. So our first case is EM. He's a 5-day-old with significant hypotonia, excessive sleepiness, and lack of interest in feeding. He's admitted to the NICU for these concerns, and the patient's mother reports that there was very little movement in utero. They note on exam that he has undescended testes and somewhat underdeveloped genitals as well. You can see very significant hypotonia. And you can see in this picture there are some facial features that we do often recognize early on with this particular syndrome. Very long face and a little bit of bitemporal narrowing. Sometimes they call those almond-shaped eyes, which can be a little bit harder to identify at this young age, and a downturned small mouth. So as you might have guessed, this is Prader Willi syndrome, and so there's many different features of PWS that we can see throughout life, and the features of PWS do change over time. So early on, as in our case with EM, you're going to see very low muscle tone and lots of concerns around wakefulness and feeding. Sometimes these kids do need assistance with a feeding tube, and typically we recommend a nasogastric tube as opposed to a more permanent feeding tube, because oftentimes over time this does get better. They can certainly have failure to thrive related to this, developmental delays. Respiratory disorders are very common, in particular at a young age could be central sleep apnea, and then of course obstructive sleep apnea is extremely common in this population. Over 80% of individuals with PWS will have obstructive sleep apnea at some time during their lifetime. They have hypothalamic dysfunction, and this typically manifests as hypogonadism, so underdeveloped genitals, as we saw in our case. There is a concern about central adrenal insufficiency, but the literature is pretty mixed on whether this is actually the case. And then central hypothyroidism is very common as well. We talked about some of the facial features, and undescended testes in males are very common. As individuals get older, the primary concerns become neurodevelopmental, as well as appetite regulation. So definitely most individuals with PWS are going to have significant delays in development and intellectual disability. Problems with social functioning and rigid behaviors, autistic-like behaviors are very common. And some of the same features we talked about, but what many people know about Prader-Willi syndrome is the transition through different nutritional phases, ultimately to something called hyperphagia. And hyperphagia is generally defined as an inability to feel full. Of course, we know that there's many different behavioral features that come along with hyperphagia. So these are the nutritional phases that were defined through the early natural history study that was done in PWS. And early on, that decreased fetal movement can be a sign of PWS. This sometimes can be really challenging to identify, particularly if it's a first time mother. Early on, the difficulties with feeding and hypotonia in stage 1A. And then stage 1B, which typically occurs around 9 months, is a period of time when feeding is generally normal and growth is normal for the infant. What's really challenging and sometimes occurs a little bit earlier than age 2 is that we can see that weight increases without a change in what families are feeding their children. So it seems to be around this stage 2A that you have a change in resting energy expenditure in PWS that can definitely spearhead a large weight gain without really an explanation based on intake. When you get to stage 2B, you start to see that there is an increase in intake of and change in appetite, but individuals can leave food on their plate, they can feel full, and then I would say typically 6 to 8, we start to see hyperphagia. And I mentioned there's a lot of behaviors that come along with hyperphagia, not just the inability to feel full, but rigidity around timing of eating and constantly asking for food can be a sign that this phase has started. And then there are a very small subset of individuals with PWS that we have seen that can start to feel full as they get into late adulthood, more like 40s. So I mentioned behavior separately because behavior is such an important piece of PWS. And in and of itself, sometimes if someone has a higher IQ, which we see a large spectrum in intellectual disability, sometimes I've diagnosed PWS just based on some of these behaviors. Very rigid, repetitive behaviors, OCD type symptoms, lots of repetitive questions. So the thing that I feel like has really helped me is parents will say they just keep asking the same question over and over again. And it's usually something that they're very anxious about. That's an event coming up, like a doctor's appointment coming up, and asking those questions over and over again. Skin picking is very common. And a lot of times around the nails, you can see this type of skin picking and pulling skin and picking at cuticles, which can cause bleeding. A lot of times, if it's on the body, it's going to be a place where the picking started with a bug bite or something that then just won't heal because of continued picking. And then certain subtypes, especially of PWS, can have an increased risk of psychotic features. And we're learning more and more about this. It's almost like sensationalizing something or magical thinking around something that did actually happen. So it's not typical psychosis that you would think about where you're responding to external stimuli or you're having hallucinations per se. So I'm going to try my stop share because I think I can talk about this, but if we can see this in action, I think it's very nice to kind of get a picture of it. So this is a video made by the Clinical Trial Consortium for drug
I kept going
companies.
back to Tom saying, God, I hope it's not Prader Willi syndrome, because what we read was absolutely terrifying. And not just for William, but for the whole family. The dynamic that it brings is so invasive on every part of your life.
Infants with PWS may be identified shortly after birth on the basis of a weak cry, hypotonia, hypogonadism, and difficulty feeding. Newborns typically stay in the neonatal intensive care unit for several weeks. suspected PWS can be confirmed by a DNA test.
I mean, we've pretty much done everything that we have been able to that's part of the modern treatment regimen at this point, which has helped a little bit. I mean, access to growth hormone has been huge because that's normalized a lot of their physical structure where they look more normal and have muscle tone and can be active. And in fact, when he was younger, before the hyperphagia kicked in, he was almost the poster child for Prader Willi syndrome. He learned how to ride a bike at 4 years old. He could go skiing. But since the hyperphagia has kicked in, the last couple of years, he's put on a lot of weight and isn't able to do any of the physical things to the extent that he was earlier.
A child with PWS will begin to gain weight very easily and may have a heightened level of focus on food. The onset of increased appetite occurs sometime during childhood and can be gradual. Increased appetite is accompanied by an increase in food-related behaviors, such as anxiety about when the next meal will come, emotional outbursts when food is denied, bargaining for or stealing food, or running away to get food.
Yeah, I'm hungry a lot. Like I'm hungry right now. It affects me a lot. I can't really control my hunger, and it's just really hard for me just to not eat like every single second.
Food intake can only be controlled by a highly restricted environment, with food locked up at all times and constant supervision. Individuals with PWS have a challenging behavioral profile that includes high levels of anxiety, cognitive rigidity, and obsessive compulsive behaviors with repetitive thinking and questioning. Disruptions in routine and unmet expectations can trigger severe behavioral outbursts.
I don't want to not do anything. I like my new gun.
William,
I will run it and run out. No, no,
As individuals with PWS enter adulthood, they are highly susceptible to mental illness, including major depression and psychosis. Excessive appetite persists for adults with PWS, who are susceptible to the complications of overweight and obesity. They also have weak bones and poor stamina, making exercise difficult. The need for constant food restriction can lead to social isolation and greatly interferes with the ability to live independently. Individuals with PWS also confront a variety of medical complications throughout their lives, which require proactive management.
If we had a drug that could help us deal with the hyperphagia and behavioral side of Prader Willi syndrome, I think it would be a syndrome that would be completely manageable and that William would have so many more opportunities to do whatever he wanted to do in life.
So I wanted to show that because I think it is really helpful to kind of see the manifestations of behavior, to see how quickly a lot of them eat. And so I think that's a lot easier to see than my talking about it. So thanks for bearing with me for the technology. So I just want to go over a few more features of PWS that we're actually really become more aware of in the last several years. So excessive daytime sleepiness is part of the phenotype of PWS. And We have recognized that narcolepsy and cataplexy like episodes that actually probably start between 1 and 3 with enjoyment with food. We have seen kids start to fall asleep while they're eating and have head drops, and we think those are cataplexy like episodes. Um, and the reason I mention this is because the excessive daytime sleepiness probably plays a role in some of the behavioral things, especially that we see with PWS, with irritability and that increased risk of outburst and getting very upset very quickly. So one thing we see with PWS is that they can be completely fine and happy, and within a minute be very aggressive and upset. And what's challenging about that is that they don't really have conceptually understand if they say certain things that can actually be very um, problematic. For example, at school, we had a patient say that he was going to shoot someone, and of course, he's very mild mannered, just has a lovely heart. He would never do that, but he didn't even really realize what he was saying or what the what the consequences could be for saying something like that. And this can get them into trouble. Scoliosis is fairly common in PWS, and I mention this because a lot of times when you look at kids on a physical exam, because they have this S-shaped curvature, they actually don't look like they have scoliosis, and it really has to be diagnosed with a film because they can have a pretty significant curve in that S shape without you being able to recognize it clinically. So we do recommend getting yearly x-rays, especially during times of significant growth. And so this is a management paper that was put out in fairly recently that our group put out to just talk about all the different things out there in terms of management of PWS. And the main reason I highlight this is that we did assign a category of evidence for to support use of these medications. The only medication that we have that's FDA approved for Prader-Willi syndrome is growth hormone, and you heard William's parents mention the benefits that he's had. We do think that it does help with maintaining lean muscle mass. There's a little bit of controversy about that, but we do see that especially adiposity around central adiposity around the abdomen area is greatly impacted by being on growth hormone. There were some papers that came out from Elizabeth Dykens' group to suggest that it may even have an impact on cognition in individuals with PWS, particularly verbal cognition. So we definitely strongly recommend being on growth hormone. And we recommend that throughout life. So when individuals become adults and their growth plates have closed, we recommend continuing a very low dose of what we call an adult dose of growth hormone because all of us still produce some growth hormone. And we do think that it has a long term benefit for individuals with PWS. There were some concerns, as you can see under special considerations, regarding an increased risk of tonsillar hypertrophy and sudden death in individuals with PWS who are on growth hormone. Subsequent studies have shown that that increased risk of sudden death is present regardless of whether individuals are on growth hormone. And then several more recent studies, including in infants, have shown that there may be a slight risk of tonsillar hypertrophy 4 to 6 weeks after starting growth hormone, but by 2 years, that risk has gone down to what it was prior to being on growth hormone. Um, so we recommend doing, the FDA recommends doing polysomnography both before initiation of growth hormone and after initiation of growth hormone. Otherwise, you can see that there's many therapies listed here. Um, most of them, if there is evidence, it's certainly not a randomized control trial, it's case studies. And then this paper also goes through all the different recommendations by age. There's so many different things that you have to be aware of throughout life. and be monitoring. And so I put that in the slide so that you all would have it, but I'm not going to go through it in detail. So one of the most exciting things about genetics is that there's really a transition in this field towards looking at therapeutic options. And so there's several clinical trials underway in Prader-Willi syndrome. One of those is carbetocin, and this is a drug that is an analog of oxytocin, but only targets the oxytocin receptor. So if you're using oxytocin, it's going to target both the oxytocin receptor and the vasopressin receptor. And so this company made a targeted molecule that only targets the oxytocin receptor. And that study just had, the phase 3 study just had some results come out. It looks like that it, at the low dose, which is dosed 3 times a day, I think it was 3.6 milligrams, did show some improvement in hyperphagia, which was their primary endpoint. And then also looks like it may be helpful for anxiety. Diazoxide choline, which is in a controlled release tablet, has been used for many years for hypothalamic obesity. And this drug also has recent phase 2 data that came out showing that this does impact hyperphagia, which was very exciting. You know, kids that were on it were able to go to buffets and eat appropriately, and there's many these anecdotal stories out there in addition to their data that really make this an exciting drug for PWS. It does have some side effects. Anybody who's used diazoxide for hypothalamic obesity may be aware of those, but in particular, hirsutism is a very common side effect. It didn't seem to bother anybody, any of the girls who were on it with PWS, but something to keep in mind. And then several individuals ended up with type 2 diabetes in that trial. And then pitolisant is something that we're very excited about. It's a drug that's actually FDA approved now in adults for narcolepsy, but it is an inverse agonist to the histamine 3 receptor, and there has been a small study already in PWS that was done by families that were importing pitolisant from Europe that showed that it has many benefits, which we think that this could be the case because it impacts that excessive daytime sleepiness, and so maybe impacting attention, which is helping cognition and learning, and some of the data also suggests that it could also be helpful for hyperphagia. So case 2, a 14-month-old female with developmental delays and low muscle tone, referred by the pediatrician. There's persistent jumps and tremors when falling asleep. She's described as a happy baby with an infectious laugh, and mother states she loves her bath time. Parents report exhaustion because it seems like their daughter does not need to sleep, and she goes to bed well but is up multiple times overnight. They've had to bring her to their bed to get any sleep. So this is Angelman syndrome. The one thing I do want to mention is that we have picked up kids with Angelman syndrome really early on, the 3 and 4 month age range, because they're not tracking. And we think that early on they have cortical visual impairment that can manifest that way, that does get better over time. So you can see these are 2 different individuals, and you can see how Angelman looks over time. The one thing I want to mention also is that they can have a very early laugh. So around 2 or 3 months, have a very infectious laugh, as was described in this case. Some people think they do get coarse over time, and I do think you can see that a little bit in these pictures. But you really get a sense of some of the features here: the large mouth, widely spaced teeth, and just that infectious happiness that even these still pictures, I think, it really exude. So the clinical features of Angelman syndrome really start with delays in development, which is typically how we pick up these kids around 6 months or so. It's noted that they have delays in their development, but they don't usually get diagnosed until between 1 and 2 years of age. And a lot of times they get diagnosed because they have a seizure. We know that in this age range between 1 and 3, that's their prime time to start having seizures. And I don't know if you can see this or if you can see my cursor, but you can see this little extra wave here. This is called a delta wave. And this is really typical for Angelman syndrome. You can see that they have an increased delta power. And sometimes just having the EEG and having some clinical history is enough for us to say that this child probably has Angelman syndrome. So this is from a 2006 article from Charlie Williams and his group. And I just wanted to point out that some of these features, so not all individuals with Angelman syndrome have seizures. You can see that seizures is listed here under the frequent findings in Angelman syndrome. And so I want to emphasize that because certain subtypes we know generally don't have seizures. So it's really the most consistent features would be intellectual disability and delays in learning and development. Movement disorders and balance disorders are pretty prominent across all age ranges. And our recent data actually shows that there may be a decline in mobility around that age 10 to 11 in individuals with Angelman syndrome. Communication across the board, no matter what subtype, and we're going to talk about the different subtypes later in the talk, but speech impairment, particularly expressive language, is very challenging in this population, and most of them do not have any spoken words. A lot of them can use augmentative and assistive communication devices um, for communication and gestures. And then that behavioral phenotype that I was talking about, easily excited, very, very hyperactive, we call it hypermotoric, is very common. Problems with attention are very common as well. Microcephaly, I would say we see in only about 50% of individuals, and it's an acquired microcephaly, so usually we see it by about 2 years of age. Gastrointestinal concerns are very high, in particular early on, gastroesophageal reflux disease and then constipation. Um, Lots of mouthing behaviors and sensory seeking, sleep disturbances, and then less common in Angelman, especially compared to PWS, would be scoliosis. Developmental dysplasia of the hip would also be there, although that's not on here. Um, and then we do see some signs that there could be hypothalamic dysfunction, definitely much less prominent than in Prader Willi syndrome. And then those ocular defects that I mentioned can be helpful in picking up Angelman syndrome early. So I wanted to show a couple of videos of Angelman syndrome if I can get these to work. I'm going to turn the sound off though. So this is a boy. He's about 2, and you can see he's still using his full hand, so not yet really with a pincer grasp as you might expect by this age. And just motor control, you can see, is very challenging for him. But he definitely does an excellent job getting across what it is that he wants, even though he can't talk for us. And then here's another video. So this is him crawling, and again, he is actually about 2. He was diagnosed very early on with Angelman syndrome based on the cortical visual impairment. Actually, I diagnosed him at 4 months. And you can see that ataxic gait is very common, so a wide base gait, arms up to balance himself. And then this is another video to kind of highlight the fine motor skills, but also just to show you, I think this video will be a good one, just to show you how smart they are. So he is absolutely a great problem solver. So I don't know um, if that was the full video, but he couldn't pick up a raisin, so he put his face down into his tray and picked him up with his mouth, which, he's compensating. He knows what he wants and he can't get it because of his fine motor control, so he improvised. Um, so, Prader-Willi syndrome and Angelman syndrome are caused by missing expression of a certain region, the 15q11.2 to q13 region of chromosome 15. And when you have Prader-Willi syndrome, you're missing the expression of that region from your father. And when you have Angelman syndrome, you're missing expression, particularly of a gene called UBE3A, right here from your mother. And there's different ways that you can have Prader-Willi and Angelman syndrome. Um, this chromosome is what we call imprinted. Imprinting basically means that, just as I said, there are certain genes in that region that are only expressed from one specific parent of origin. And so with this region, it's a very specialized chromosome in this way. There's only a couple of other examples of imprinting. Um, the other one primarily would be chromosome 11. But you can see that um, depending on what's missing and from who that parent of origin is, you would have Prader-Willi or Angelman syndrome. So you can have that occur by several different mechanisms. The most common mechanism for both is non-allelic homologous recombination. So along this chromosome, there are repeated regions, duplications actually. And so when um, the chromosome goes to align, if it doesn't align appropriately, then you can end up with a missing part of this chromosome. And that's a similar mechanism to many chromosomal disorders that we know of today. Um, Similarly, you can have a situation in which you have um, inherited for Prader-Willi syndrome 2 copies of mom's chromosome 15. And that can happen by 2 different mechanisms. The one that we typically think about is something called trisomy rescue. So you have a pregnancy that's actually a trisomy 15, and the body knocks out one of those copies of chromosome 15 to have a viable pregnancy, and ends up, in this case, taking out the only maternal copy of chromosome 15 and causing uniparental disomy. So you can have a similar mechanism where you end up with 2 copies of dad's chromosome 15 to cause Angelman syndrome. And then for Prader-Willi, the third cause would be an imprinting defect. Also for Angelman, you can have an imprinting defect. What that means is that in our germ cells, we have to remark all of our chromosomes as coming from that particular parent of origin. And if that process doesn't work properly and that chromosome doesn't appropriately get marked as coming from, say, dad and Prader-Willi syndrome, um, that can cause Prader-Willi. There's 2 different mechanisms that we classify for imprinting center defects. One of those would be that there's a small deletion in the imprinting control region. So the imprinting control region basically controls how this region gets expressed, and it's located on the SNRPN gene, which is a long transcript. Um, so we know that there can be a deletion, and it is important to continue that workup to identify if there is a deletion causing an imprinting center defect, because depending on the parent of origin, if that deletion was inherited, say, from dad, there's a 50% recurrence risk of having a child with Prader-Willi. And the other classification for that imprinting center defect, which is definitely more common is something called an epimutation. And we don't fully understand what epimutation causes this. There's still some work to do there. There is a fourth cause for Angelman syndrome, and we know that the gene that causes Angelman syndrome is UBE3A. Now, there is some genotype phenotype correlation with the different subtypes of Angelman syndrome, and in particular, the deletion that includes this whole region. In particular, if it's the large deletion from breakpoint 1 to breakpoint 3, those kids do tend to have more seizures. So we're not really sure if these um, GABA genes, which are GABA receptors, play some role. But in general, we know that if there's a maternal mutation in UBE3A, that also causes Angelman syndrome. And so, just briefly talking about treatment for Angelman syndrome, we are working on a standard of care document for Angelman syndrome. There really isn't anything out there. The one place where there is some evidence, and we do really support this in our clinic, is ketogenic diet or low glycemic index treatment, which is a less strict version of the ketogenic diet, can really impact seizures. And there has been some studies on exogenous ketones as well, um, and hopefully we'll have that out soon. But it may be that those may be helpful as well for the treatment of seizures. The only other thing I want to mention, which I don't think I made a slide because I don't know that it's the right audience, but the best medications in terms of treating seizures for Angelman are really benzodiazepines, and that is really because we know that not only can those GABA receptors be impacted by having a deletion, but we also know that there's a problem with tonic inhibition of the GABA receptor in Angelman syndrome, and so those medications are really important for treating seizures in this group of patients. So I talked about all the different causes for Angelman and Prader Willi syndrome, and you can see the deletion is by far the most common cause. Uniparental disomy seems to be more common in PWS and less common in Angelman syndrome. For PWS, I don't know if I would. It depends how you think about this. So there are mutations in MAGEL2 that have to be paternally inherited. MAGEL2 is a gene that's in this critical region of chromosome 15, and that causes a separate syndrome called Chaffee-Yang syndrome. But there is some overlap with Prader-Willi syndrome, and if you can identify a genetic cause for PWS, it's worth looking into MAGEL2. But for Prader-Willi syndrome, we really have not identified the specific cause of PWS. There's a lot of speculation going back that this SNORD116, which is a non-coding RNA in this region, really plays a huge role. It definitely regulates many other genes and many other genes in this region. And there have been some papers that have come out in individuals who have um, isolated mutations or isolated deletions, I should say, that just include that SNORD116 region, and most of them also include this IPW, and those individuals do recapitulate many of the phenotypic features of PWS, and we would diagnose them with PWS. Um, we talked about imprinting mutations; those are by far less common, and then you can have a balanced translocation that um, can impact that imprinting control region and can cause PWS. And that's really important because that also has a recurrence risk if there's a balanced translocation in a parent as well. So just thinking about the workup in, generally if you're thinking about developmental delay, many of us would start with a chromosomal microarray. And then if that's abnormal and you have a deletion, you would go on and perform the DNA methylation to determine if it's either the paternal copy that's missing or the maternal copy that's missing. Um, if you really suspect PWS or Angelman, we actually recommend starting with DNA methylation. These days, a lot of us do both at the same time if we really think that that's the diagnosis. But the gold standard, and if you wanted to start with one test, you would start with the DNA methylation test. If that microarray is normal, but you still have a suspicion, um, this you could, if you think it's Angelman syndrome, you certainly could start with um, doing sequencing and deletion duplication analyses. Um, it depends on where you started. If you started with the DNA methylation test and your chromosomal microarray is normal, then you want to do um, polymorphism studies to make sure that it's not one of the types of UPD that we wouldn't pick up from a chromosomal microarray. And if that's normal, then go down the route of an imprinting defect. So I just wanted to briefly talk about where we are in terms of therapeutics, particularly with Angelman syndrome. And there were several things that really had to happen to get to where we are today in 2020. So, Harry Angelman described Angelman syndrome in 1965. He called it the happy puppet syndrome. And then in 1987, we discovered the gene um, that causes UBE3A. The gene UBE3A is on chromosome 15. And specifically, that gene was identified in 1997 as the gene that's responsible for Angelman syndrome. And we know a lot about how this imprinting occurs. I'm not going to go into too much detail. The point here is that UBE3A is only imprinted in the central nervous system. So in the periphery, it's expressed from both copies. And we know how this occurs. We know that there's a UBE3A antisense transcript that's expressed on the paternal copy of chromosome 15 to cause it to be silenced. Um, and so, and you know, we have come a really long way. And one of the most exciting things about this region of chromosome 15 is that, particularly because we know how to um, silence the paternal copy of chromosome 15, this has really lent itself to turning back on the paternal copy of chromosome 15 as we've learned more and more about how this regulation occurs. And so this is a very exciting paper that came out looking at topoisomerase um, or topotecan. Topoisomerase inhibitors are an example of topotecan. And you can see that in this paper, they were able to reactivate the paternal copy of chromosome 15. And so we are on the road to therapeutics for Angelman syndrome, both from a gene therapy perspective and giving back UBE3A protein, and that's underway from several companies. But we're also working on reactivating the paternal copy of chromosome 15, and that's come a really long way. At this point, we are in phase 1/2 trials of antisense oligonucleotides that are targeting that UBE3A antisense. So thank you all for your for coming and listening, and I'll be happy to take any questions at this point.
Great. Thank you so much, Dr. Duis. This was a wonderful presentation. We did have a couple of questions come through. I'm going to try to read these off as best I can. We do have one from a nurse practitioner who is currently working with Dr. Elias in Montana. And what was submitted here is we frequently see patients who are obese with hyperphagia with concerns from the primary care provider for Prader Willi with the absence of hypotonia and or feeding difficulties. Are you aware of any positive cases of Prader Willi when hypotonia and feeding difficulties are absent in the neonatal infancy stages? At this time, we often are still testing for Prader Willi, although we know there is likely a low diagnostic yield when hypotonia and feeding difficulty is absent.
So, hypotonia and feeding difficulties are present in about 90% of individuals with PWS. But there's still some individuals who get by where parents, sometimes it's experienced parents, sometimes um, parents are just persistent, and some patients get by where it's not recognized in the infant stages. And so I have a 6-year-old that I've diagnosed. I've seen 16-year-olds diagnosed because um, even if there was some low muscle tone or problems feeding, it's not really something that the parents ever were concerned about or recognized. So we still do recommend, if you're seeing obesity and hyperphagia, to go ahead and get methylation testing to rule out PWS. The challenging part is that also depends on age. If someone's 1 and they're already obese and parents are saying they're just hungry all the time, that's much less likely to be PWS until they're more in that stage of decreased resting energy expenditures, which I would say at least age 2. So it depends on the presentation, but generally without hypotonia and feeding difficulties, we still would say go ahead and rule it out.
Great, thank you so much for that. We do have a question that came in from Rachel Friedman, who is a board certified behavioral analyst at the Wyoming Institute for Disabilities at the University of Wyoming. And it looks like Rachel has a comment along with the question. Many of the behavioral characteristics of PWS overlap with autism spectrum disorder. Examples include engaging in repetitive behaviors and compulsive rituals, severe tantrums, challenging behaviors in response to denied access to food, self-injuries, behaviors, restricted interests, anxiety fixations on upcoming events, difficulties tolerating changes in the schedule or routine. Even though this special interest fixation for individuals with PWS are primarily food-centered, there are many similarities to individuals with autism. Is it possible for an individual with PWS to also receive a diagnosis of autism in order to access ASD-specific services? Example, applied behavioral analysis services.
This is a great question. We frequently will diagnose individuals with PWS with autism. Some of them clearly have classical autism. I have some patients who have a clear dual diagnosis. Um, but many of the features that they have do qualify them for a diagnosis. And we do it just for the reason you mentioned, that it does offer lots of services to them. In particular, they can respond really well to ABA therapy. So we will frequently do that. I would say in any given clinic, we'll see 8 patients. I probably half of them I'll work with to get a diagnosis of autism so that we can get them some services.
Great, thank you, Dr. Duis. We do have a question that came in from Kristen Bennett. I don't know if you can actually see that, but it looks like there's some information that was included that you may be able to interpret. If you wouldn't mind just answering that question for us, please.
Um, I think it would be helpful to know a little more information. Um, has methylation been done on this family?
Kristen, you're definitely welcome to type that information in for us.
So there are individuals who, with a deletion, it'd be less likely to be mosaic Angelman syndrome, but there is some overlap between Angelman and Prader-Willi syndrome, and the more highly functioning the individual, so the better the receptive language, the better their mobility, the more we see that overlap. So hyperphagia has definitely been something that we've been looking at in Angelman syndrome, and it is very prominent in individuals who have mosaic Angelman. So those individuals typically have an epi mutation. There's one case that I've become aware of where there was failed trisomy rescue. So some cells have trisomy 15, and some cells have um, two copies of chromosome 15 that originate from dad. And so that individual has mosaic Angelman. But yes, we do see overlapping features. And I also want to comment that the uniparental disomy subtype of Angelman syndrome is very much behavioral. They do have hyperphagia. They have some of the most significant hyperphagia of the Angelman kids that we see that don't have mosaic Angelman. Um, so certainly there is overlap between the diagnoses that we're seeing more and more.
Looks like Kirsten did continue with the comment here. Not sure, however, we are considering a referral to Denver for further workup. Both are in EI, where I provide nutrition services, significant developmental delay in the 2-year-old, 7-month-old doing better, both with G tubes, poor feeding, and don't appear to want to eat.
I would strongly recommend sending them. There could be a translocation that is increasing the risk, or an epi mutation. I would probably would be a translocation though, since um, it looks like there's something in the chromosome 15 region. But I would definitely refer them to see us. I gave my email in the beginning of the presentation, and I can put it in the chat box as well. Um, so I'm happy to help with this case if I can be of help.
That's great, Dr. Duis. Thank you. And we did have another question come in from Stefan. Are most patients with Angelman syndrome eventually able to develop some speech?
Most of them are not. Certainly, we have some mosaic Angelman individuals who do have over 1,000 words, but for the most part, they don't develop any speech. And if they do, it would be single words, mama, um, you know, but typically, no. Not right now, but hopefully to come with the therapies.
Great. Thank you for your question, Stefan. Kirsten just chimed in and said thanks. She will discuss with the PCP.
Perfect. Thank you.
We do have about 7 minutes left for our audience, so I'm happy to take any additional questions in our chat room if anyone has questions. We'll go ahead and wait for just a little bit here to see if any additional questions or comments come through. Otherwise, we will go ahead and proceed with wrapping up just a little early today. Okay.
It looks like there was one question about ketogenic diet and PWS.
Yes.
So there is a lot of focus on a higher protein, lower carbohydrate diet for PWS. There was a recent paper that came out looking at modified Atkins diet. Um, the idea is that, well, there's several that we think about. One of them is that switching over to ketones, we think, can be helpful in terms of managing appetite. And there's some data about beta hydroxybutyrate, which is a ketone, that it does impact acylated versus unacylated ghrelin. So ghrelin is our hunger hormone, and it's abnormal in PWS. It seems to be that it's elevated all the time from infancy on in PWS. So some people have thought about it from that standpoint. If you can tip the balance to the inactive ghrelin with the ketogenic diet, will that impact appetite? The other reason is that just in terms of increased risk of diabetes and We know that simple sugars, they raise your blood sugar very quickly and then drop it very quickly. And so thinking about steady insulin release and not having that increased um, release, increased sugar very quickly and then dropping it, we wonder if that will help maintain euglycemia a little bit better in this population. And then also, there's not great evidence, but we wonder if it helps with maintaining muscle mass. The bottom line is that there isn't clear evidence of what type of diet these individuals should be on, but that they do need portion control, and that they definitely need less calories than a typical individual the same age. So we don't, depending on how active the individual is, we would never increase calories to what you would expect for a typical individual the same age. They have that decreased resting energy expenditure, and they definitely need some restriction in portions or restriction in calories.
Hmm. Thank you. We have one other question that came in. Have you seen better outcomes with PWS children without G tubes, with them having better feeding skills? I find getting adequate fluid into the kids with previous G tubes has been greatly difficult compared to the children who are able to feed PO from birth.
Yeah, this is a wonderful question that we've been thinking about a lot lately in our clinical trial consortium and our clinical research consortium for PWS. There's some early data from Angelman showing that individuals who have G tubes have increased complications. So fistulas that form that never really heal. So lots of um, uncommon complications of G tubes are common in this population. We we also know that, or we theoretically think that individuals with PWS are at increased risk of gastric necrosis. That's a little bit worse with a history of a G tube, and so gastric rupture is also potentially a more of an increased risk. We also think that gastric emptying is somewhat changed by being fed through a G tube, and that this can become a major problem in this population. Certainly, we're not recommending Nissen fund duplication for reflux for this reason. Um, so we, and then the reason you mentioned that it seems like working on feeding skills and pushing water and oral intake early on seems to be really important. And so we're pushing for a consensus statement from our group to really say that all these kids should have NG tubes until they're ready for feeding by mouth. Now, of course, that there are obviously other considerations, whether the family could handle the NG tube. And so it would be a case by case basis, but we really strongly recommend that we try to avoid G tubes in this population.
Great, thank you again. Well, it looks like we are at the end of our virtual education session today. Um, Dr. Duis again has kindly shared her email address. So anyone who has any final questions that we were unable to address today, please feel free to submit those questions to her email.